Good morning. Good morning, everyone. Oh, good, we've got the mics working. Thank you to the folks that did that. So I'd like to call to order this informational hearing of the Committee on Health, Finance, and Policy. And I'm just really glad to see all of you. It's been quite a while, and it's exciting to be here. And I'm especially excited with what we have for you today, which is what should be a really interesting, exciting hearing on managed care. And I just wanted to say that one of the reasons that we wanted to do this hearing is that in the last session, of course, we started very, very quickly. And normally at the beginning of the two-year term, we have a lot of informational presentations just to help people get oriented and understand some of the terms and understand what the state is doing. And I think back to when I was new in the legislature, I had no idea what managed care was. The term PMAP, Prepaid Medical Assistance Program, like who knows what that is? I think most of the public has no idea how we run our public health care programs. And yet we had no time to do anything with that. So I hope that this hearing will fill some of those gaps for folks. But I want to just start, though, by saying that the folks that are presenting today are experts in their fields. They are academics from the University of Minnesota, and we have a very special guest as well from NCSL, which is the National Conference of State Legislatures, who is here as a policy expert on this as well. We're not hearing today from the agency itself. So I just want to put that out there for everyone, that there may be questions for the agency about how things are done, why things are done a certain way, but that's not really what we're doing today. We're really doing more background. And there's certainly, the agency folks have told me they're willing to answer some brief questions if there are some, but that's not really, because there are agency people in the room. But really, this is to get the background and to hear from some of the researchers on the sort of the bigger issues and questions and how managed care works and so on. So I did ask our fiscal folks to, Mr. Berg is here, and I asked him to put together for me just kind of the overview of how much we spend on MA. And because I just wanted to put this in focus, why this is such an important topic. We spend a lot of time on things that are about the smaller money, right? But we spend north of, this is the state share of MA spending, just the state share for 24 and 25 is north of $15 billion, just the state share. And for the out biennium, it's about 18, getting close to $18 billion. So this is a big deal. And that's just the money, not to even speak about the lives we touched. You know, at one point recently, there were about 1.5 million Minnesotans on our medical assistance program. Of course, our Minnesota Care program is much smaller. But so this is about a lot of lives and a lot of state dollars. And so how we deliver these services is just critically important. How we're spending this money and whether we're getting what we should be getting for it is a critical topic for us as policymakers. And yet it's so complex that a lot of times it seems out of reach, and it's really hard for us as policymakers to do the kind of oversight and management of the system that we really ought to be doing. So before we get started with the first presenter, and I do just want to express my gratitude to them. They are coming here as volunteers. Lynn Blewett, who's going to be speaking to us, really helped bring this together and organize it, and has worked very hard on this. And we're just so appreciative of that. In terms of questions from the committee, I think the best thing would be for us to do what we normally do during our committee in session, which is if you have a question that is impeding your ability to understand what's being said, like what is that acronym, by all means raise your hand. We'll keep a list, and we'll get to you and we'll try to clear that up. If you have a question beyond that, please jot it down, wait till the speaker is done presenting, and then we'll have a question period for that speaker, but we will try to, we plotted out quite a lot of time for this. We have a lunch break built in. We're planning to go until 3:30 or so, or even a little beyond that. But, we'll just see how it goes. Maybe it'll go faster, maybe slower. But I think I hope you're all going to be quite interested in what is being presented here today. So, and as always, I do want to thank our staff. Ms. Niedernhofer is working very hard to get all of this out to everybody and get all the copies of all the presentations. And also Josh Sandy, who's been working on this to pull this all together. So with that, let's start with our first presenter, who is Dr. Golberstein from the university. And welcome.
Madam Chair.
Yes, please.
Can these be emailed to us as well? Can we get these electronically real quickly?
Yeah.
Like right now, or do we have to wait until after? Thank you so much.
You're sending it out right now? Okay, excellent, excellent. Representative Kwan?
Thank you, Madam Chair. You gave the portion that MCO, can we have the total amount in the budget for medical plus the percentages in the programs, the MCO versus pay per service, so we can have the full picture and understand? Because we've got people in the public watching, and I just would like them to have the full picture. Thank you, Madam Chair.
Well, Representative Crum, it sort of wasn't, this isn't really that date. We're going to hear a lot about the MCOs generally and what the spending is in a later presentation, but I think Mr. Berg heard it, and he can maybe email that out.
Yeah, Madam Chair, Representative Quam, I'm going to have to follow up with you on that. The way, at the level I look at the state budget, the general fund balance, it doesn't split MA into parts. I mean, it does, but not that part. Managed care versus fee-for-service is not a standard reporting category at the state treasury level, so I'll have to connect with the department on that.
All right, so.
It's a knowable number, I just don't have it in any data I can access right now.
All right, and as always in committee as well, if there are questions, we'll be keeping a list, and we'll get to you. So if you do, during the presentation, if you have a question that, can wait, but you want to be on the list, signal us, and we'll put you down, and then we'll get to you in order as we usually do. So welcome to the committee. Dr. Golberstein, I hope I'm saying your name right.
That's great. Thank you so much for having me. Representative Liebling and all other state officials, representatives, and committee members, thank you for being here. Thank you for having me. So I'm Ezra Golberstein. I am an associate professor of health policy and management at the University of Minnesota. I'm a health policy researcher and health economist. I'm going to take about 30 minutes to provide some high-level background, both on the Medicaid program and on the role of Medicaid managed care. And I'm going to touch on issues both nationally and more local to Minnesota. And I just want to quickly note I'm not aware of any conflicts of interest that I have that are relevant to any of this discussion.
And Dr. Golberstein, I think we might need to do something with the mic here, because your mic's a little bit soft. Right. Or maybe you could just be closer to it.
Yeah, I can probably lean in a little bit more. Is that working better?
Yeah, I think so.
Okay, great. So make sure I'm on the right side here. Wonderful. So just to start with, it's important to underscore the overall importance of the Medicaid program. So Medicaid is the main public insurance program for low-income populations, and about 1.4 million Minnesotans are covered by Medicaid. That's roughly 18% of the entire state's population. Medicaid is not important for just one particular area of the state. Medicaid beneficiaries are in all of Minnesota's counties. It is a critically important program for both urban and rural areas of the state. It's useful, I think, to consider the role of Medicaid coverage for different population groups. Okay, thanks. So I do think it's useful to think about what Medicaid's role is for some specific population groups, and recent data is illustrated on the right side of this slide in the graphic show that, if you look at the non-elderly adult population, 1 in 6 non-elderly adults are covered by Medicaid. Medicaid is even more important as a source of insurance for kids. About 3 in 10 kids in the state of Minnesota are covered by the Medicaid program. And related to that, Medicaid pays for approximately 1 out of every 3 births in the state of Minnesota annually. Medicaid is particularly important for people who have disabilities and who use long-term services and support or long-term care. As you can see on the graphic here, 5 in 9 nursing home residents are covered by Medicaid in Minnesota. 1 in 3 people who have a disability in Minnesota are covered by Medicaid. And then finally, for those who are enrolled in the Medicaid program, the program covers an extensive set of health care services. The services that are covered by Medicaid are on par with, or sometimes even more expansive than services that are covered by commercial insurance plans or by the Medicare program, the federal program for the elderly and some disabled populations. So next, I want to talk briefly about how Medicaid is financed. So Medicaid covers, as you saw on the last slide, many people's health care services, and health care is just simply very, very expensive. So consequently, the state spends a lot of money on its Medicaid program. In 2022, the state spent about $15 billion on its Medicaid program. And if you look at that spending strictly in terms of the state's budget, that comes only from state funds, you can see on the upper pie chart here, the upper pie chart on the right illustrates that Medicaid is the second largest spending category in the state budget after elementary and secondary school spending, accounting for 18% of spending that's just directly from state funds. However, the state is not paying for Medicaid on its own. Medicaid is a federal-state partnership program, and the federal government subsidizes our Medicaid program to the tune of over half of total program spending. For most Medicaid beneficiaries in Minnesota, the federal government covers half of their costs. But for a subset of Medicaid beneficiaries, those who are childless adults that are covered under the Affordable Care Act's Medicaid expansion, the federal government is much more generous with its subsidy and covers 90% of total program costs. So if you look at the state's budget after accounting for the federal dollars that are coming in to subsidize this program, and this is shown on the bottom pie chart on the right here, Medicaid is the single largest single spending category in the state's budget and accounts for 29% of state spending. Again, when you are accounting for federal dollars that are also coming in to pay for things. So when we're thinking and talking about Medicaid, although it is technically one single program, in many ways it's like 4 separate programs that are rolled into one. And this is because Medicaid just covers some very different populations, and these populations have distinct eligibility rules, sometimes with different rules about what is covered and how those services are covered. And this is to say nothing about the distinctly different healthcare needs of these different groups. So as mentioned before, a large share of children and childbirths are covered by Medicaid, and in Minnesota, Medicaid extends coverage to 12 months postpartum. A separate group is non-elderly adults who do not have a disability, and this is the group that has that highest federal subsidy level. And then finally, as I noted on a previous slide, 1 in 3 Minnesotans with a disability are covered by Medicaid, a population with an incredible amount of vulnerabilities and healthcare needs. And then finally, many people whose primary insurance is Medicare, largely because they are 65 and older, but some people who qualify for Medicare on the basis of disability are duly eligible for Medicaid. And the way that that works is Medicaid covers the cost sharing in the Medicare program, along with paying for services that Medicare does not cover, and that's namely long-term care, long-term services, and supports. So these 4 populations have very different healthcare needs and use quite different profiles of healthcare services. So an implication is that Medicaid as a program needs to be a flexible and expansive program to effectively serve such different groups. Another implication is that the program costs differ substantially from group to group. While children and adults without disabilities account for the significant majority of the total Medicaid population in Minnesota, they account for less than half of total program spending. And that's both because those populations tend to be relatively healthy and not use much healthcare services, relatively speaking. In contrast, even though people with disabilities and people who are duly eligible with Medicare account for a much smaller share of the program's enrollment, they account for most of the state's Medicaid spending because they have just far greater needs for healthcare services, and because services related to disability that are used by Medicaid enrollees with disabilities and who are dual eligibles tend to be relatively more expensive services. So overall, I think it's reasonable to think and characterize Medicaid's role in several ways. The first is just that Medicaid is a profoundly important support for our overall healthcare system. And as Medicaid focuses on lower income populations, the program is just critically important for maintaining the overall healthcare safety net in the state. You can look, I think, at some more specific categories as well. So Medicaid is the main payer of mental health services nationally, and it's widely understood that we have huge mental health challenges right now, and Medicaid is going to have to play a large role in addressing those challenges. I've touched on this already, but Medicaid is also the main payer of long-term services and supports nationally, so it plays an enormous role in the lives of the people who rely on those services. It's instrumental for assuring access to children's health care services and for promoting child health. And as we work to advance health equity in Minnesota, Medicaid plays a really central role given that racial and ethnic minority populations are disproportionately represented in the Medicaid program. If we want to reduce health disparities, we have to be focusing on Medicaid. Second, another way that we can be thinking about Medicaid is that Medicaid can pose a budgetary challenge, and this is true for every single state. This is not a Minnesota-specific issue. Even though the federal government heavily subsidizes our Medicaid program, Minnesota still needs to fund a large share of the program's substantial costs. And this is a budgetary challenge that's most acute during economic downturns, because that's when more people need to rely on Medicaid as a source of insurance. And at the exact same time, that's when state revenues are falling. I'll note that the recent economic downturn associated with COVID pandemic is sort of an outlier here, because there have been extraordinary infusions of cash from the federal government, both through the Medicaid program and outside of that as well, which has helped to buffer those pressures that otherwise we would have experienced. And then third, I think it's actually underappreciated that Medicaid can be thought of as an investment of sorts. Specifically, we have very good research evidence that Medicaid coverage, particularly in childhood, can lead to cost savings in the future from several different pathways. And this year, the Nonpartisan Congressional Budget Office put together a review of this evidence and concluded that long-term fiscal effects of Medicaid spending on children could offset half or more of the program's initial outlays. So as a federal-state partnership program, each state administers its own Medicaid program, and then the federal government just subsidizes a share of the program costs. And this is a very large infusion of federal funds, and states have to play by certain rules in their Medicaid programs in exchange for accepting those federal funds. And there are a broad range of federal rules for Medicaid programs. However, at the same time, states really do have a lot of latitude and flexibility in how they choose to implement many of the details of their Medicaid programs. Each state can decide what their specific eligibility rules are for each Medicaid population within certain boundaries set by the federal government. Their states have discretion over what services will be covered. Some services are mandatory to be covered by Medicaid in exchange for accepting the federal subsidy dollars, but other services can be included at the state's discretion and still receive those federal subsidy dollars. States can also decide how much to pay providers and facilities under their Medicaid program, subject to admittedly hard to define and sometimes hard to enforce federal rules that rates can't be so low as to compromise Medicaid beneficiary access to services. And in fact, if you look across states, you really do see a tremendous amount of variation in Medicaid payment rates to providers. States also have discretion in how they operate certain administrative processes in their Medicaid program, such as how to enroll and processes for redetermination of eligibility, just to name a couple examples. And so that brings us to the type of Medicaid flexibility that really is the focus of today's hearing. Every state has to make a choice with their Medicaid programs. They can make their own Medicaid program, which is to say they can directly administer their own Medicaid program and run it directly out of the state. Or they can sort of think about it as buying their Medicaid program, which is to say they can outsource the administration of their Medicaid program to private managed care organizations. nationally, there's been a very strong trend over the past several decades towards more of the overall Medicaid population nationally having their Medicaid benefits administered and delivered by private managed care organizations. The vast majority of states use some sort of comprehensive managed care model at this point. And typically, if you look at the map, the states that don't use managed care tend to be states that are predominantly rural states where it's just a little bit harder to implement managed care models. Overall, 72% of Medicaid beneficiaries nationally were enrolled in a comprehensive managed care organization in 2022. So what has been the reason for why so many states have embraced private managed care organizations as the vehicle for delivering their state's Medicaid benefits? And there are a number of reasons and arguments have been put forth. One is that to the extent that the private sector might be able to operate more efficiently than the public sector, it could represent a way to achieve some cost savings for states. More specifically to managed care models and managed care organizations, managed care has a well-established set of tools to control levels of healthcare service utilization and spending. This includes things like defining provider networks and a range of utilization management tools and techniques, which can include primary care gatekeeping models or prior authorization processes. And these tools are especially important in the context of the Medicaid program because Medicaid is generally not allowed to have, depending on the population, either any cost sharing for services or really anything beyond nominal cost sharing for services, which is for other types of insurance plans, one of the main ways that you can try to control patterns of utilization and spending. So if these utilization management tools do reduce costs, some of those savings could in theory be passed along to the state, and some of those techniques could in theory also try to promote higher value and better health care. Another argument is that outsourcing to private managed care organizations can, in theory, create more budget predictability for state governments. And I'll discuss this more shortly, but annual state Medicaid spending is the product of the annual number of people that are enrolled in a state's Medicaid program and the annual spending per enrollee. Outsourcing to a managed care organization or organizations can allow state governments to lower the uncertainty around annual spending per enrollee. Another reason is that any health insurance plan is simply going to involve a lot of administrative and bureaucratic functions. Some states just might prefer to outsource those functions rather than doing it themselves in-house. Some people have argued that an advantage of relying on private insurers to deliver Medicaid benefits is that it could potentially reduce the stigma that's associated with using public programs for some people. Getting your Medicaid services delivered via a private insurer might just feel more comfortable for some people who might be more likely to sign up for services and actually use those services if it comes from a private insurer compared to if it were being run directly by the state. And then finally, outsourcing to private managed care organizations can be a mechanism to create incentives and promote accountability for high performance. States can design contracts to incentivize improved access to care and quality of care and lower costs of care. And if a plan is underperforming along any of those dimensions, a state can hold them accountable by choosing to not renew their contract. Managed care is itself, I think it's fair to say it's a nebulous term, and there are a number of different models of implementing Medicaid managed care. One of the most common models is one that's called comprehensive risk-based contracting. Under this model, the state enters into a contract with managed care organizations where the state pays the organizations a fixed amount of money, and in return, the managed care organization is responsible for delivering the full set of Medicaid benefits that beneficiaries are entitled to under the state's coverage policies and decisions. The payments from the state to the managed care organizations are capitated payments, which is a fixed amount of money per beneficiary, per month, or per year. When a managed care organization takes on capitated payment, they are accepting financial risks for the delivery of Medicaid benefits to that population. If the covered population ends up using more services and costing more than anticipated, the organization is at risk of losing money on the contract. On the other hand, if utilization is lower than was anticipated, the managed care organization could make money off of the contract. Federal guidance exists about how Medicaid managed care capitation rates should reflect the expected healthcare spending for the population. So that's one very common model. We use it in Minnesota, but there are other methods of Medicaid managed care contracts as well. Another prominent model is partial rather than full risk capitation. And in this model, a managed care organization might receive a capitated payment for a lot of the services that are delivered to Medicaid beneficiaries, but not all of the services. And other services can be what's called carved out of that contract. And those services could then be delivered directly by the state government, or it could be delivered by a separate, maybe more specialized managed care organization. Some of the most common types of carved out services nationally are listed on the slide here. They include mental health services, pharmacy benefits, dental services, and long-term services and supports. States can also choose to implement their Medicaid managed care programs for different parts of a state. So maybe only certain counties, maybe say urban counties, but not rural counties. A state can do that if they want. They can also choose to use managed care differently for different population group or eligibility groups within their Medicaid program, owing to the significant differences in needs and services across these eligibility groups. And then finally, while states have a lot of discretion in how they design their Medicaid managed care contracts, there are still federal rules that constrain some of the elements of Medicaid managed care contracting. So here is a profile of the share of Minnesota's Medicaid population that's enrolled in managed care. This is from fiscal year 2021. I don't think that the numbers have changed that much in the past year or two, though. Overall, about 82% of Medicaid beneficiaries in Minnesota receive services via a managed care organization. But you can see that this proportion does vary across eligibility group. For children and non-disabled adults, which includes both the new adult group and the other adult group, these numbers are over 80%. They're close to 90% for some of these categories. However, for the populations of people who have disabilities and for the aged population that are duly eligible with Medicare, the proportions are a bit lower, and it's notably lower for the population who qualify for Medicaid on the basis of disability, where just over half of that population is enrolled in a managed care plan. And it's worth noting this is a pattern that is actually quite similar if you compare Minnesota to other states. When a managed care organization takes on a Medicaid contract, it's also taking on a number of requirements. And so some of these requirements are listed here. This is really summarizing information from the DHS website. So a managed care organization is going to have to define and maintain a network of providers where its Medicaid enrollees can go to receive care, and it can limit care to in-network providers for most services. The managed care organization determines how services are delivered and determines whether processes like prior authorization or whether referrals are required for certain services are going to be used and under what circumstances would they be used. It's also up to the managed care organization to decide how much to pay providers, and that's going to come out of negotiations with providers, although states have the option of specifying certain payment rate parameters for certain services, which they might particularly be interested in doing if they're concerned about providers being underpaid for certain types of services or certain types of providers. There are requirements that urgent care and emergency care have to be paid for by the managed care organization, regardless of whether the service is out of the provider network for the managed care organization or even out of the managed care organization's service area. And certain services are considered open access. For instance, an example is family planning services. And for services that are deemed open access, the managed care organization has to cover those services for their enrollees from any provider, whether or not that provider is in network. And then finally, managed care organizations are required to have adequate procedures in place for dealing with members' grievances and appeals. So a little bit more about some of the details of Medicaid managed care in Minnesota. And I just want to note that Minnesota actually has a fairly long history of using managed care models in its Medicaid program. We started with this in 1985, which was relatively early compared to many other states. So it's fair to say Minnesota was an early adopter of Medicaid managed care. If you look at where Minnesota's Medicaid spending is going, 49% of total program spending was in the form of payments from the state to private Medicaid managed care organizations in fiscal year 2022. So how do we square that 49% with what we saw in previous slides about the high rates of enrollment in Medicaid managed care in Minnesota was 82%. There's two ways. The first is that if you look at the profile of the populations in Medicaid, among the more expensive populations, of particularly people with disabilities, the rates of managed care enrollment are the lowest in Minnesota. And the other reason is that for a handful of services, including some nursing home services, those are services that are carved out of those capitation contracts and are just paid directly by the state. The method by which the state procures its Medicaid managed care contracts is really quite important. I'm going to just touch on this very briefly, though. I'm not going to go into all the details. In Minnesota, we use a competitive bidding process to decide which managed care organizations will be operating in which counties, with a goal of having at least 2 managed care organizations per county, which both facilitates beneficiary choice of plan and hopefully promotes competition between managed care organizations as well. When a managed care organization wins a contract, it is for 1 year, but it can be renewed for up to a 5-year period, after which there's another competitive bidding cycle. Each state that uses competitive bidding to select its Medicaid managed care organizations, and not all states actually even use competitive bidding, but every state has its own competitive bidding process. And in Minnesota's most recent bidding cycle, the process involved a few steps. Plans submitted their proposals to DHS, which graded plans on a number of criteria which were clearly laid out in DHS's request for proposals. These criteria included organizational capacity, provider networks, plans for improving beneficiary health and improving health equity, plans for implementing value-based payment to providers, and plans administrative processes. Based on, so DHS basically gave grades to all of the applicants based off of these criteria, and that then led, and then the leading plans based off of those grades were selected to enter into rate negotiation with the state, and then contracts were finalized. The most recent round of competitive bidding in Minnesota yielded 9 managed care organizations that are delivering Medicaid benefits in the state. So a natural question at this point, I might imagine, is, well, what does Medicaid managed care even do? Does it, in fact, perform better than when a state just directly runs its own Medicaid program? So to try to answer that question, we need to zoom out from Minnesota, I think, and look at what the research evidence says nationally. And this is a pretty large body of research, and yet the answers, I think, are a bit unsatisfying in that they're just not that definitive. My assessment is that there is absolutely good evidence that exists that managed care can, emphasis on can, achieve goals like modestly reducing costs, improving performance in terms of access to certain services, and improving quality of care in some ways. But when you look across this entire body of research, just because Medicaid managed care can lead to some good outcomes does not mean that it always does. And my assessment is that the overall research evidence suggests that Medicaid managed care does, in terms of its overall effects on costs of care, quality of care, and access to care, I characterize the evidence as being somewhat weak and fairly mixed. But that assessment comes with some really big caveats. The first is that the research literature on Medicaid managed care nationally is just looking across a whole lot of states. States use very different managed care models and mechanisms, and they use them for very different populations. As such, it's fundamentally hard to come to systematic conclusions about the effects of Medicaid managed care because oftentimes we're not talking about apples to apples comparisons. We might be talking about some very different things. The second caveat is that when you look at Medicaid managed care organization performance within a state, we have what is very compelling evidence from several states, not Minnesota, but from a few other states, that different managed care organizations can have very different levels of performance within the same state. So we should be really mindful that when we are thinking about what the evidence is out in Medicaid managed care organization performance, it does not always generalize to Medicaid managed care as a whole, and the specific organization really does matter. And then finally, with respect to the research evidence on whether Medicaid managed care actually saves states money, I think it's important to note that much of the best research evidence in this area comes from studies that really focused on the population of children and non-disabled adults in Medicaid, and those populations are the relatively less expensive populations in Medicaid anyway. And from a Medicaid program's perspective, there might not even be as much potential to achieve such large cost savings to begin with. So just a few caveats about that literature. I'm happy to talk a little bit more about it. I know that some of my other panelists today also have expertise in this. So that's it for our overview. Thank you for being here, and I'm looking forward to more discussion.
Well, thank you so much for that. So you covered a ton of information, and I think even with our late start, I think you got through really on what we thought was going to be your time, but I know there was a lot in there. We have one question from Representative Quam, and then if, we do have a few minutes, so if there are some questions, maybe, go ahead, Representative
Thank you,
Quam.
Madam Chair. There's some additional information I didn't see. I'd like to understand when you've got the, profit information, I'd like to see the clawback of excess profits, because there's a history of that, so we can understand if that's rolled into your charts already and exactly what that ends up being. And county-based purchasing, we need a chart breakdown just for those, because they do not have the profit margin that you're showing in the general. And I think we're going to be discussing them, so it'd be nice to have that data. The other thing is you go over the expansion of the market boundaries
Wait,
and hospital mergers.
Representative Quam,
I'm asking for additional information.
I know, but I want you to ask one that he can answer, and then, because you're I'm
giving him-
losing track of all the questions. I want to make sure he can answer, so.
Well, I'm asking for him to provide offline this additional
Offline.
detail,
Okay.
Yeah.
because it was things that we're missing.
Offline, okay.
Yeah,
So,
Representative
Madam Chair,
Lieberman.
the expansion of market boundaries for hospital mergers, et cetera, you didn't include Mayo in that, because Mayo has been expanding its health service and acquiring hospitals in greater Minnesota, and Mayo stretches across multiple states and internationally. And I think they've got a pretty good model, but if you overlook them, I think you don't have a fuller picture of the entire situation. I didn't see any delineation of the abnormal effect of COVID and the injection of billions of dollars from the feds on the profit margin. And other than, I did notice there's a correlation between same profit margin basically for the managed care organizations on your charts and the adult or Minnesota senior health options. And I think there's a huge correlation for the seniors for COVID impacts and the additional billions of dollars that flowed in. So that kind of breakdown will help us take out the abnormal, and so we can analyze the system going forward in a more normal state. So those are the types of things that would illuminate for me a better understanding of your presentation. Thank you.
All right, thank you, Representative Cron. We have a few more members on the list, so let's go to Representative New Brindley.
Thank you, Madam Chair. And thanks so much for the presentation. That was really informative. My question, on your last slide, talking about sort of the evidence of how this is functioning and how this is working, you noted that within states, the performance can vary a lot across MCOs. How accessible is that information right now?
Dr. Goldstein.
Representative Liebling, Representative Brindley. So what I'm speaking to there is several recent research studies that have been published that have looked at evidence from the state of New York and the state of Texas, and I believe the state of Louisiana as well. I believe that this information is publicly available in some way. I know I have access to all of these papers, and I could certainly share that.
Representative New Brindley, was that
Is
what
that-
you were?
Thank you,
What
Madam
you're
Chair. Yes, I mean, so really, there have been studies that have been done on this, but this is not necessarily information that's readily accessible to DHS year over year, it sounds like.
Well, that might be a different question, whether it's available to DHS.
Sure, and I guess what I'm getting at, Madam Chair, is that that is a really critical piece of information that would be good for us as legislators to figure out. How do we make sure that DHS has that kind of information when they're making decisions each year? So thank you, Madam
Right.
Chair.
Yeah, well, thank you, Representative Brindley. I think in that question, if I'm not misreading it, is maybe the question for Dr. Goldstein of, do we have information to measure the performance of our own system here in Minnesota? Do you know, are there, because I know a lot of this is national data, but, you know, to your knowledge, is there good research showing how well we are doing comparing? And I know this has been a thorny thing, so, you know, it's not that clear of an answer, but anyway, I'd love to hear your take on that. Is that, Representative Brindley, that's kind of sounds like where you're going, right?
Thank you, Representative Liebling. So, you know, this is, I don't have a good answer to that. I'm not directly aware of any particularly good research evidence about relative performance of managed care organizations in the state of Minnesota. You know, it's as a health economist, when you try to understand what are the effects of a particular insurer, it's just fundamentally hard because people choose insurance plans typically, and it makes it hard to say, like, what is the effect of performance versus just underlying characteristics of enrollees. And other states actually randomize enrollees to managed care organizations, which allows researchers in New York and Louisiana and Texas to actually study those effects. We don't do that, I think, as assertively here. I think we do it a little bit, so there might be opportunities to try to study that more effectively in Minnesota, but I'm not aware to date of any really strong research that I've seen.
Right, thank you for that. And I think that, in fact, is kind of one of the big concerns that's been expressed over the years since I've been in this legislature, is that we do this in a certain way. We obviously spend a lot of money on it. There are, from time to time, concerns about how well it's working. And yet we don't really have, you know, since we were one of the early adopters from 1985, when it was called a demonstration project, I think it still is, and it still hasn't been demonstrated in a clear way exactly what the impact is. Let's go to Representative Elkins.
Thank you, Madam Chair. Just had a quick question. Ezra, are you familiar with are medical loss ratio requirements common or uncommon in state level Medicare managed care contracts?
Dr. Goldberg.
Yeah, Representative Liebling, Representative Elkins. Yes, minimum medical loss ratio rules are common across state Medicaid programs, but as with everything else in Medicaid, things do vary a lot state to state. They vary in terms of what the level of medical loss ratio is. Now, there is some federal guidance about what that minimum should be. I believe it's 75%, but I'm not 100% sure about that. 85 now? Okay, thank you. 85% now. But states have, I think, some latitude with where that specific number is, but also on how aggressive they are in clawing back money if the medical loss ratio is not being met. There's, you know, plenty of states are doing it, but it varies a lot.
Do we do it?
Okay.
I believe we do.
All right, Representative Elkins?
Yes, I was asking if we're one of those, and I think the answer was yes.
Yeah, right, we are one of those. Okay, Representative Breyer.
Thank you, Madam Chair. Thank you, Professor. This has been very useful and interesting. My question is about provider reimbursement rates and the relationship of higher or lower relative reimbursement on outcomes, on performance, on whatever measures might have been studied to date, because we know from medical providers, mental health providers, dental providers, across the board, low reimbursements are a challenge. And I would even argue that reducing stigma becomes more of a problem if someone goes in with a card that looks like anyone else's, but then are turned away because they're not accepting Medicaid patients. So I wondered if you could comment on that whole area. Nothing too specific from me, just thoughts.
Dr. Goldberstein.
Sure, thank you, Representative Liebling and Representative Breyer. So there is absolutely, I would characterize it as good evidence. This is evidence that is national evidence. It's not Minnesota specific, but evidence that when Medicaid programs pay lower rates to healthcare providers, it does lead to poorer access to care. And this has been demonstrated for a number of services, including mental health services, as you noted. So I think there's very compelling evidence that this is absolutely an issue. But I think that there's actually even more to the story than that, which I think is important to understand, which is that it's not just that Medicaid, in most states, Medicaid is a relatively low-paying provider, low-paying insurer compared to Medicare, and especially compared to commercial insurance plans. But in many states, and I'm being very clear, I'm speaking nationally here, Medicaid programs and Medicaid managed care organizations, the combination between the two, are administratively difficult for many healthcare providers to deal with. And there's increasing evidence that it's not just that fees are relatively low in Medicaid, but that Medicaid is administratively burdensome for healthcare providers to work with. And that combination really is part of why providers are sometimes more reluctant to take on Medicaid patients.
Representative Breyer.
Thank you, Madam Chair. Just a quick follow-up. In programs that are more fee-for-service based, is there more administrative simplicity if they're managed by the state rather than going through a multitude of managed care plans?
Dr. Goldstein.
Thank you, Madam Chair, and Representative Breyer. I can't point to a study that I could give you a definitive answer on that. I can certainly imagine that happening, but it really depends on what sort of the baseline of how the state's actual fee-for-service Medicaid program is being run. And sometimes states actually do things that are very managed care-like in their fee-for-service Medicaid programs as well. So that, that's the comparison you have to make. But I certainly could imagine that, particularly if providers are dealing with multiple managed care organizations, that could be an additional hurdle.
Okay, we have Representative Smith and Fisher, and then I think we'll go on to the next presentation. Representative Smith.
Sure, thank you, Madam Chair. Thank you again. I'll echo what my colleague said. This is a great presentation. We have a section here that we talked about motivations for Medicaid managed care, and that's from our perspective as a state agency wanting to get that Medicaid coverage. You talked briefly, and I want to expand on this, on the motivation for companies, for-profit companies, to enter into comprehensive full-risk contracts, or the capitation rates. You mentioned that their profit is reliant upon that bid that they put in and a capitation rate basically being lower in actuality than what they put in. Is that correct?
Dr. Goldstein.
Madam Chair, it's whatever. Yeah, it's the difference between whatever the accepted negotiated final rate between the state and the company is, and the actual experience of healthcare spending over the year. But I'm not sure if I missed something else there.
Representative Smith.
Just to, thank you, Madam Chair, just to simplify maybe, if there is, the cost of care is less than the contract that the state paid, the remainder goes to that company as a profit.
Dr. Goldstein.
Madam Chair, Representative Smith, thanks for the clarification. Right. So yes, yes, and so that is where any potential profit is going to be coming from that contract. But, and this relates to Representative Elkin's question, there are rules about medical loss ratios. So a managed care organization can't go below, there's a certain amount threshold that they have to be paying out from the money that they are bringing in from their contract, has to be paid out for medical benefits. And if it falls below that medical loss ratio threshold, then the state can be clawing back some of that, which really does create at least some ceiling on what the magnitude of those profits can be. But that all depends on what that loss ratio is set by at the state and how aggressively the state is actually going to be clawing back.
Yeah, and if I could just add to that too, it also depends on what we define as part of the administrative expense, what's acceptable, and that was changed a few years ago. So go ahead, Representative Smith.
I think that's a good clarification. Thank you, Madam Chair. I guess maybe just a final follow-up to that. Would you, in your expert opinion, I'm asking you personally, say then that these companies have some sort of profit motive to deny care or make care difficult so that they have more? Is there some profit motive for not delivering on all care requests because if they go above a certain amount, they're starting to lose money on that? And maybe as a follow-up, I'll ask, we mentioned this $15 billion figure that the state of Minnesota, and we say that we have spent on Medicaid managed care, and part of that $15 billion is going to a company as profit. And so I guess my question is there some incentive in this system as it's set up to not provide care?
Dr. Goldberstein.
Thank you, Madam Chair, and Representative Smith. Sorry,
Yes,
there's a lot of
sorry, my
names and I
nameplate
can't
is
see
way
them.
over here.
Okay, thank
Yeah,
you.
you got it.
I don't think that this is unique to Medicaid managed care. Any time that a health insurer receives a fixed amount of payment to deliver care for a population over a period of time, if you are looking purely at a profit motivation, yeah, there certainly can be a motivation to deliver fewer services. That is, I would say, also tempered at least somewhat, though, by other, even profit motivations. There's no managed care organization or insurer that wants to end up on the front page of a newspaper for denying care to enrollees, and generally these managed care organizations are going to want to continue their contracts with the state, and I think that organizations are very mindful that if they do deny care in ways that are really inappropriate, that is going to really compromise their ability to continue contracts with the state into the future. So, it's a balance of those things. But all those motivations, I think, do exist.
And Dr. Goldberstein, this might be a moment to maybe mention that there was a recent study at the federal level of prior authorization, I think denial of care in managed care, in Medicaid managed care. And I don't know the degree to which this is a Minnesota issue, but I think I don't know if anyone of the other presenters was going to mention that, but you don't know what I'm referring to, I guess?
Representative Liebling, there are actually a few studies that you could be referring to that I have in my mind right now. It's a very active area of research. This is actually something that I was alluding to a little bit earlier, which is that it's not just Medicaid payment rates, but also administrative processes. And part of this is from sometimes from states and also sometimes from the Medicaid managed care organizations. And this really reflects just the fundamental nature of Medicaid as opposed to every other type of health insurance, in that cost sharing is just not used really barely at all in Medicaid. And every other type of health insurance relies very heavily on cost sharing, deductibles, co-payments, co-insurance as a way to contain utilization. Statutorily, you can't do that in Medicaid, yet you need to have some mechanism for controlling utilization and spending, which is why things like prior authorization tend to be used more aggressively in Medicaid managed care compared to other types of insurance. So it's absolutely is a thing. We do have evidence. I think that I think it's a developing research literature, but we are developing evidence that it is potentially quite important for the actual experience of healthcare delivery for people on Medicaid.
Okay. And finally, Representative Fisher.
Thank you, Madam Chair. You're kind of touching on where my questions were going to be coming from. First of all, Mr. Goldberstein, thank you so much for being here today. This has been very helpful. Going right into what we were just talking about are there some good evidence out there of showing what is happening with denials and pre-authorizations, and in terms of breaking it down between fee-for-service, between MCOs, whether they're for-profit, non-profit, and we also have county-based programs. And I hear in some instances it's very much easier versus others with pre-authorizations, because you also get denials and pre-authorizations, and they have to jump through hoops. And this gets back to the whole administration thing that we were talking about before, is if you get, particularly on smaller clinics that are independent, it's much more challenging for them because they don't have the large resources. Sometimes they forego getting reimbursed for lower cost procedures because it takes more time to go through the appeal on the denial process, et cetera. So, is there any study showing how that's impacting out there, and which parts of the populations are suffering more in those kind of situations than others?
Dr. Goldberstein.
Yeah, Madam Chair and Representative Fisher, it's a really excellent question, and it's one that I wish I could give a better answer to. And it's one, and it's not because I'm not trying. This is, in fact, something that I personally have been trying to research for the past several years. It's very, very hard to be able to find useful data that is actually representative of what's happening on the ground here, because this information tends to be totally proprietary. You can find sometimes information about denial rates, but for pre-authorization, prior authorization, that's extraordinarily hard to come by. And so, there's absolutely, we hear a lot. There's tremendous anecdotal information out there that this really matters a lot, as you are suggesting, but there is just a limit of the information that we have, and I would actually add, this could be a priority to try to make that information much more transparent, and I think that a lot could be gained from that.
Representative Fisher?
Thank you, Madam Chair. What would we need to change? What are things that we could change on the state side to help make that information more available and readily available to researchers like yourself so we can get these answers? What needs to be changed?
Dr. Goldberstein.
Madam Chair and Representative Fisher, a state could mandate that as part, when a managed care organization enters into a contract with the state, that they are going to be agreeing to provide full information about what are their rates of use of prior authorization for which services is it being used, how frequently is it being used, what are the, how long does it take for the average prior authorization per service. All of those things would give a lot of information that we really currently don't have information on. Some other states have started doing this. I believe Michigan last year or the year before passed a law that I believe is going to require at least some health insurers, I'm not sure if it's in Medicaid or not, to start providing that information publicly.
Thank you.
All right, thank you, Representative Fisher. And Representative Bonner, something real quick, and then we'll go on to the next presentation.
Just briefly, thank you, Madam Chair. I did want to mention, and I will send this to the committee administrator and to the chair, of course, but I do have an article from the Kaiser Family Foundation that talks about an issue brief that found that 99% of Medicare Advantage enrollees, and I'm not sure if this is the one we're referencing here, were in plans that require prior authorization, particularly for things like mental health services and so forth. And a recent report from the U.S. Department of Health and Human Services, Office of the Inspector General, found that 13% of prior authorization denials by Medicare plans were benefits that should otherwise have been covered by Medicare. And I think I have a more recent article as well, Madam Chair, that I will send to the administrator in case folks are interested.
Okay, thank you. Dr. Goldberstein, did you want to comment on that at all? Okay,
No.
all right. Well, thank you so much. And you're going to be here, right, for a while. And thank you so much. It was a very good presentation. Really appreciate it.
Thank you for having me.
So we will move on now to Dr. Blewett, who is going to talk with us a little bit more about county-based purchasing and IHPs, Integrated Health Partnerships. Oh.
Good morning. Thank you so much for this opportunity, Representative Liebling. My colleagues and I spend a lot of time studying these issues, and we don't often have a time to come and communicate our ideas and thoughts with the committee, so with the legislature, so we really appreciate the opportunity. And I would say we enjoy coming up here. And I didn't have to, pull on any arms for my colleagues to join me today to provide you with information. It's things that we think a lot about, we study. And I also want to highlight that we have quite a few students here today. They're very interested in the legislative process and what you think, what kind of questions you ask. And I'm going to ask them to stand up because we have 3 PhD students and then a bunch. Come on, you guys. You can stand up, wave.
Yeah, please do.
And then the other students are getting their masters in public health. Oh, we have 4 PhD students. There we go. So say hello to them, and they're watching.
Oh, wonderful.
And
Thank you
maybe
for being
future
here.
legislators. So thank you, students, for showing up. Okay, so I'm going to talk about the two innovations that Minnesota has done with service delivery, the county-based purchasing and integrated health partnerships. So Minnesota healthcare programs use four primary delivery system models: fee-for-service, which pays for every service provided; managed care organizations pays on a per member per month, as you've heard from Dr. Goldberstein, on full risk model for covered services. That's primarily what he covered. And I'm going to cover these last two boxes: county-based purchasing, which is also paid on a per member full risk model with the county or affiliated counties; and then the integrated health partnerships, which is direct contracting with affiliated provider groups. And I'll go through each of those. So Minnesota county-based purchasing is basically a health plan that's operated by a county or a group of counties to provide services to Minnesota public programs. It's an alternative to our existing Minnesota managed care organizations, and counties accept full financial risk through a capitated payment, and they agree to provide the full range of MA-covered services. This has been around for a very long time. 1982, there was initial county-based demonstrations that were funded by the federal government, and these occurred in Hennepin County, Dakota County, Itasca County. Hennepin has its own model that it has grown over time. Dakota County chose not to continue to participate, and Itasca has been the longest-running county-based purchasing program, and it still exists today. The federal authority expanded the program in 1985, and then there was bipartisan legislation in this legislature in 1997 to authorize these programs. In 1998, the South Country Health Alliance was the first county-based purchasing plan. And again, Itasca is the longest-running plan. The county boards are in charge. So it's like a health plan run by a county board. Or affiliated county boards that agree through joint powers agreements on their administrative role. They get capitated payments similar to the HMOs. It's the same rates. It's the same methods for developing the rates that they receive. They must meet all of the Medicaid MCO requirements from DHS and the MDH MCO regulations. They develop their own local provider networks, they develop payment rates, they contract with third-party administrators to process the claims. So they really operate similar to the Medicaid HMOs, but they're county-based and run by county administrators. This is the map that the Association of County Health Plans provided, and it shows that we now have 3 major county-based purchasing plans that operate in 33 counties and serve just a little over 100,000 enrollees across the state. So Itasca is the one program that is just a single county organization that's headquartered in Grand Rapids. It serves about 10,000 people. Then we have Prime West Health, which is the purple counties. That's the largest of the plans. It's governed by 24 counties and serves about 60,000 people. And then the South Country Health Alliance is the green, marked with the green categories, which is headquartered in Medford, and it's includes 8 counties, and serves a little over 30,000 enrollees. So it's the total's a little over 100,000. It's not a lot of enrollees compared to the Medicaid enrollment population, but it serves particular needs in the rural parts of the state. So historically, the federal policy by the Center for Medicaid and Medicare Service has to increase the number of Medicaid beneficiaries served under managed care or contracted payment arrangements. They have viewed this as a cost-saving, administrative simplicity, to have consistency across programs. And they approved the county-based purchasing as a way to move the Medicaid managed care out into rural areas. So when managed care started in Minnesota, it was primarily in the 7-county metro area. So this is to try to, provide services across the state. From a county perspective, the advantages of working directly with local communities are there is some more autonomy in local level, at the local level in clinical decision-making. The local-based care management is closer to the beneficiaries, they're closer to the providers, and they can be responsive to unique rural healthcare needs. They keep the revenue in their rural areas, and they're traditionally they support locally based providers. And there's additional opportunities for a county-based system to coordinate with their public health, social services, housing services for the members. They do also participate in the competitive bidding process, similar to the MCO. So during the procurement process, there's an RFP issued and they submit applications. They're evaluated and scored on performance, service deliverables, and care coordination models, among other items. And DHS has been focused on having at least 2 plans, either a county-based plan, purchasing plan, or an MCO within each county. Right now, every county has at least 2 plans except for Itasca, which is the only county served by 1 plan, Itasca Medical Care. So some of the policy issues related to this initiative is should the county-based purchasing plans be required to compete with Medicaid MCOs by requiring 2 plans within each county that basically sets up a competitive strategy, competitive market between plans. Residents can choose between the county-based purchasing plan or the private plan that's offered. Counties could consider that, there's already limited number of beneficiaries, there's a limited number of providers, that really doesn't set up well for a competitive market for 2 plans when there's just such a low supply and low demand. But consumers also, if there's less than 2 plans, they have limited choice. If you're a Medicaid beneficiary and the only option is the county-based plan, there's limited choice of option there. There's some DHS and county tension over the procurement process. The main issue is whether the county-based plans can operate only 1 plan per county. And there have been 3 lawsuits over the past 3 years over this procurement process. And the last, there's a current lawsuit moving its way through the court system, and the Supreme Court of the state of Minnesota has recently agreed to hear the 3rd lawsuit. So this is a contentious issue, although I do think the department and the counties are working together on ways to move this issue ahead and come to some agreement on some different innovations and strategies to serve the rural areas. And then finally, an additional policy issue is whether there should be separate rules for county-based purchasing. Are they really different from an MCO, and should they be treated differently? Right now, they're treated exactly the same and have to meet the same requirements. Okay, I'm going to move on to integrated health partnerships. So both of the integrative health partnerships are what we call the Minnesota Medicaid value-based payment model. And it's moving toward a model where you're paying for value and quality and moving the contracting down to the provider level. So it's DHS directly contracting with provider organizations, and these organizations, so it would be hospitals and clinics, are affiliated to agree to provide a set of services and meet quality and total cost of benchmarks with the state. The populations covered can include the Minnesota healthcare programs, either the fee-for-service, those enrolled in the fee-for-service model, or in the Medicaid MCO models. And again, the IHPs directly contract with DHS. This chart might be helpful to look at how the state contracts with first of all, the Medicaid agency. So at the top, the payer is the state Medicaid agency. And the typical way that the state contracts through what Dr. Goldberstein was discussing was a contract with managed care. So there's 2 purchasers here on the managed care plan. And then the managed care plans contract with provider organizations, either through health systems, which are on the, which is the Independent Practice Association, or a hospital. So these are clinics and hospitals, so health systems, and then individual providers on the bottom. So DHS contracts with managed care contracts with the providers. In the ACO model, the IHPs are organized provider organizations that agree to take capitation and provide services to the Medicaid population. So in essence, the state is directly contracting with the IHPs, and they're not affiliated, or I guess they can be affiliated, but typically they're not associated with the managed care plan. So these integrated health partnerships provide the full scope of MA services through a voluntary contract with DHS. It has to have the capacity to accept financial risk and under a total cost of care risk arrangement. So they provide information on total cost of care and quality metrics, and DHS provides payment. They have to be able to submit and receive routine data on the cost of care and quality. They must address social determinants of health, and they must coordinate with local community organizations, counties, and local agencies. This IHP term is a Minnesota-specific term. It's a Medicaid Accountable Care Organization, or Medicaid ACOs, and there are states across the country that are pursuing this. And again, it's just to think about providers who are affiliated together and have come together in a contract to agree to provide services for a set number of population, of set population. Again, the incentives are to move the incentives down to the provider level. So it's between the provider and the patient, and to more directly, instead of contracting with the managed care, contracting directly with the providers to try to incent providers to provide effective quality care, effective case management, and to do that in a cost-effective way. This is a trend toward, so each IHP receives an attributed population from the department. They establish a baseline cost based on this population. There's usually a 3-year contracting cycle. They estimate the total cost of care, and then they estimate what the total cost of care is going to be in the future, and they agree that they're going to meet those benchmarks in terms of total cost of care. And then once the total cost of care metrics are met, there's also they have to meet quality metrics. And then there's a calculation of the loss and savings to the IHP, and the payment is directly to the provider organization, although it's coordinated through Medicaid managed care. So that's kind of, it's a complicated system, but yes, it is complicated. So here's this chart again. So think about, this is DHS provides the provider organizations the attributed population. So here's your group of enrollees, Medicaid enrollees that you're responsible for. And then the IHP or the providers provide back data to the state in terms of quality metrics and cost of care. DHS also provides information on who are those patients, what are their risk scores, who are they, what do they look like? And so it's really trying to use a data-driven management tool down at the provider level to drive quality care and provide incentives at the provider level. The IHP has 3 specific payments. One is this loss gain payment. So if they are below their capitation and meet the quality metrics and have met their total cost of care requirement, they share in either with DHS with either the loss or in the gain. So there's agreement between DHS and the IHPs in terms of the payment. They also receive quarterly population-based payments tied to health equity interventions, care coordination, and other activities, and that's again based on their population that they're serving, and it's a very small amount, but it's again to sort of promote the health equity interventions and the care management. And then they also receive quality payments to support the child and teen checkup outreach, again focused on families and children. This is the quality domains that are in the total cost of care measure. Just to give you an idea, all of these break out into very specific metrics, which I don't have time to go through, but you can just see the type of thing that they're collecting data on, submitting data on, and then actually being rewarded for meeting their quality, their cost targets and their quality targets. Here's a visual of the IHPs across Minnesota. So this program started in 2013, covering about 100,000 Medicaid beneficiaries. And now we have 28 IHPs covering about 500,000 beneficiaries. There's more than 500 different provider locations and more than 10,000 practitioners who participate in the program. DHS estimated the total savings from the program from this 5-year period from 2013 to 2021 at $444 million to the state was a savings. And they also estimated the share savings returned to the providers over this same time period as $172 million. So that is payments to the independent health plans who've met the total cost of care requirements and the quality metrics. CMS, so this is the federal government, has pursued a national accountable care organization strategy. And many of you have heard of the triple aim. The idea is to improve patient care, to improve health of the population, and reduce per capita costs. And the goal is to push down to the provider and the more local level in terms of incentives and cost containment. This chart is just to show kind of this concept of moving. This is, you start with the degree of provider integration and accountability. In a fee-for-service model, there really isn't any coordination of care or quality metrics. The state just pays for the service. They get a bill, they pay for the service. There might be some data, that they receive, but primarily it's not an integrated care. There's primary care integration, performance-based contracts, there's bundled payment, and then you get into these shared savings, shared risk, and fully capitated models. And the accountable care organizations fit into this model, which is a movement, and I would say kind of a general trend in the financing of healthcare to move away from fee-for-service and into more capitated arrangements. But with incentives, I think both the county-based purchasing and the integrated health partnerships are trying to push the incentives to the local level and to the provider, patient, to provide total cost of care and patient care management. Minnesota is one of 14 versions of the Medicaid Accountable Care Organization. So all of these states have pursuing, and again, as Dr. Goldberstein alluded to, each one is very different and unique. And I think our representative from the National Council of State Legislatures is going to talk about some of these initiatives that are being pursued in these states. For example, Oregon has gone full bore into ACOs and now directly contracts with ACOs. And throughout the state, they're geographically located, and that's their primary financing mechanism. This is just to highlight the trend of both in the public and private sector of moving to more ACO contracts. And this is just a trend from I guess those numbers are a little bit funky. I guess it's quarters. So like 2010 up to 2022. Medicaid is this gray line on the bottom. Medicare ACOs is the trend in the orange. And then the commercial market is also using these shared saving total cost of care and total cost of care ACO models at the commercial level. So this is, I guess, Medicaid is a little bit behind it, but it's a model that exists in all payer types, and it's an important part of the reforming of the healthcare delivery system models. The IHP process procurement is request for proposals is out, and I'm not sure if they're close to signing those contracts, but it's in the process. Their innovations, what they call the 2.0 version, is to expand this model to new geographic areas, to try to do more integration with clinical and mental health service, safety net providers, and social service agencies. They have requirements to look at social determinants of health and agree upon health equity measures and health equity initiatives, to coordinate with local providers and agencies, and then also to work on both with providers and the county-based purchasing plans on issues related to population health goals. Again, looking at the geographic areas and local population health goals. So the policy issues here, which I'm sure you can have seen through my presentation, is it's a complex model. So these enrollees are already enrolled in managed care, and they're now an attributed population to a provider organization. So, so there's kind of a layering of payment and structure for the Medicaid population across the state of Minnesota. And a key question is, how do you attribute the cost and outcome achievements to the IHP or to the managed care organization? And so there's a layering of responsibility and accountability for both cost and quality metrics. And then how do you encourage collaboration between the managed care organizations and the IHP, and to, if there is some overlap in responsibilities, how do we identify that? How do we work on integration and coordination across those systems? And to think about who's accountable for what outcome. And I would say there's limited program evaluations in terms of what works, what's effective, and they're really critical for making decisions and thinking through sort of what is the future going to look like for Minnesota, and especially rural Minnesota, in terms of county-based purchasing, integrated health plans, and then this overlay of the managed care organizations. So I think it's these new innovations at the local level and focused on providers, and then our more traditional kind of infrastructure of the managed care organizations, which still exists with these pockets of innovation. Okay, thank you.
Thank you so much, Dr. Blewett. So I'm gonna ask the first question here. So, thank you. That was really, and I asked her to speak about IHPs for the clear reason that I don't understand them. And you can see maybe why. And so, Dr. Blewett, so why do we have, to your knowledge, I know, again, she's not the decision maker here in any respect, but why do we have this ACO or IHP model on top of the MCO model? Why are we taking people who are in MCOs where already we've supposedly shifted the risk to the MCOs, and then working with providers outside of that for many of the same patients to do this IHP thing? Do you understand? If you don't understand that either, it's fine to say you don't, but why do you?
I think our managed care infrastructure has been here in Minnesota for a very long time. It's, there are states who are moving to managed care now. I put Minnesota in the mature managed care markets. There's a limited number of managed care organizations that participate in the Medicaid program, and so they have very large patient populations, and they contract with a large number of providers. So having being able to affect and provide incentives at the provider level becomes very different when you have contracts across all the provider systems. So I think the IHP and community-based purchasing, I think, works the same way, is it's targeted towards a patient population that's manageable, it's geographically located, and so you can coordinate with existing agencies and services. And so it's a new model of care that is trying to push the incentives and the service delivery approach to the local level, as opposed to these big health plans who have a lot of incentives, a lot of patients, enrollees, and it just to be more effective in terms of both total cost of care, quality, equity, management of services, and locally based care provision.
So that being the case, it sounds like the IHP system could even replace managed care, and it sounds like maybe in some states it kind of does. Is that accurate?
I think some states have moved towards ACO models. There are different types of ACO models. One is county-based purchasing. In Oregon, they have, it would be, it's not just provider organizations, but it's also agencies, county agencies and public agencies. So it could be a different type of model, but I think the trend is toward more locally based care provision and more defined population management of care.
Okay, great. So I have three other members on the list. So Quam, Fisher, and Nadeau. So Representative Quam.
Thank you, Madam Chair. And first, it's nice that there's some positive, cheerful, nice, good information in this. One is, with 100,000 people, on your one slide with the savings, that's over $4,400 in savings per person. And then the IHP came out to be a little over $1,700 savings per person. So let the people out in the public know we're doing good things that actually save money. We don't get many things to talk about that. I also liked about your, the coordinated and support structure is better, and I think that's the key to the savings. But on the question side is, I'd like information on the percent of administration costs for the CBPs versus the normal MCOs, because I think there's a big distinction that is part of the reason for the savings. And the other thing, can you explain to me between the CBPs, the county-based, and the fee-for-service, my understanding, fee-for-service, there's a more restricted list of people they can go to, where the county-based purchasing allow for some out-of-network and still do some coverage of the cost on those.
Okay, so Representative Quam, I think your first question is probably for DHS more, and I'm sure they heard that, and maybe they can provide that later. And then maybe the second
Yeah,
question.
and Chair Liebling, Representative Rum, I'm not sure on the second question. My thought would be that the fee-for-service has broader access. The county-based purchasing has to have network. There are certain services that you can receive out of network. So I think that, again, might be a DHS question. Sorry, I can't answer it.
Thank you, Madam Chair. I think that it's nice to understand the differences, but I believe I've met with and talked to people that are in the county-based purchasing. And the coordination was the biggest thing that they liked. And the other thing was the concept of fee-for-service, a fixed network that might be larger, but there are some things that are out of network that might not be covered. Thank you.
Thank you. Okay, so I've got Fisher, Nadeau, Elkins, Ryer, and New Brindley. Representative Fisher.
Thank you, Madam Chair, and thank you, Dr. Blewett, for your presentation. I will have to admit, I'm going to have to watch it again afterwards, because the IHP was a lot of stuff coming at me. So I want to say thank you for what you're putting, for the information. The one area I did want to dive into a little bit that caught my attention is when you're talking about the county-based plans, and then again, you were mentioning under the IHP program, is the social service connections. And what are some, and particularly when I heard the word case management, it really struck me. Can you tell me a little bit more what that looks like and what that involves?
Dr. Blewett.
Chair Liebling, Representative Fisher, I can tell you in general, and then for the specifics, you would want to go to those different the different county-based purchasing plans. I mean, generally, if your county-run program, and Hennepin Health is probably the most advanced here. If you're a county-run Medicaid program, you're co-located with the county-based social services. And so that includes housing, income supports, employment, other social services, mental health services that are funded differently than Medicaid. And being co-located and under a county board administration is just it's an easier vehicle to coordinate. And it's a county-based program, so there's incentives to coordinate.
Representative Fisher.
Thank you, Madam Chair. And in terms of their interest when they're, coordinating things back and forth, when they have the rates that they're using on the medical side, are they able then to use some of those same expenses to help with their case management and the coordination of services in that regard?
Chair Liebling, Representative Fisher, yes, they could use their savings to do different things. And again, it's county administered, so they can make a decision about how to use those savings to increase managed care or increase coordination of care. Or, and they can also leverage those other services that are there that are funded through a different mechanism.
Representative Fisher.
Thank you, Madam Chair, and thank you. That's what I thought I was going to hear. And part of it is what I've seen working in the homeless youth world and working with a lot of different clinics and different settings is when you've got these wraparound services, the outcomes that you have greatly improve from where they are before because you're getting them connected. If you've got somebody who's in the emergency room in the Medicaid population, they're homeless and they've got diabetes, being able to connect them and they're unstably housed or they're food insecure, being able to tie them into the county management, the case management, increases their stability going down the road, gets them connected with the other services, and gives us the better outcome. And I kind of think this is when we're talking about possibilities out here, and there's still more I need to learn here, but it feels like this is where we need to start evolving, creating our healthcare system to evolve from where we've been to the next level. And I think the next level is getting it all around a whole what I would call set of services, not just a medical, but bring everything together so that you're treating the whole well-being. And I think, what I'm seeing in the county-based programs, that's where they're meeting. It seems they're the leaders, and it's been what we've seen in the past. It's the locals that have the tendency of leading the states that in turn lead the federal government. And I think this is an area that we should be doubling down on and supporting and take a look at some of the policy things that were suggested out here to encourage this kind of growth in this area.
Thank you. Representative Nadeau.
Thank you, Madam Chair. And thank you for that presentation. Have you done work on the ACOs? When those things started, they picked a pretty expensive population, or what they thought was a pretty expensive population, put a PMPM on it, and then handed that very distinct population over to those ACOs. And then over the years, we found that number one, they weren't as sick. It wasn't as costly as we thought they were to begin with. That was number one. And number two, those successful organizations were those ones that were vitally connected to social services. And we aren't counting those costs for housing and stepping down out of medical facilities that are integrated into the ACO model. Is anybody doing any work to identify those additional costs associated with that? That's number one. And number two, where are those cost savings going? When we find those interventions that actually are impacting those healthy outcomes, oftentimes those incentive payments aren't going to the intervention that's actually doing the work. And so is anybody doing anything? I mean, again, I haven't been on ACOs for a couple of years, so I'm not familiar with where it's gone since then. But what's happened recently in measuring those impacts? Do you know?
All right, Dr. Blewett.
Chair Liebling, Representative Nadeau, there isn't like systematic information across the country on the effectiveness of ACOs, and the most work has been done in the Medicare front. And it's what do I say? There's no definitive evidence of effectiveness or non-effectiveness. It's really hasn't had a huge impact at the local level, at the patient level. And again, this is a Medicare population. I think there's a lot of interest in thinking about social determinants of health and thinking about services outside of the medical domain that contribute to the health of populations. And so the one way to do that is to try to coordinate those services outside of the medical system. And so the ACOs are, and the county-based purchasing are one way to kind of think about how can we do that, or how can we effectively incent that? Because there isn't typically incentive to do that, to provide for services that are not in your contained, covered service list.
Representative Nadeau.
Thank you.
All right, and I was going to say too, maybe some of your question is more for DHS, like where do the savings go? I think that would be one that I hope they're listening and can kind of make note, because that is a piece of information that we'd like to all
Right.
know. Thank you.
And they choose the populations too, which
Right.
is, and then they choose the population.
No, your point is very well taken. You know, this is very, this whole issue has not been discussed a lot in the legislature, and this is one of the reasons I wanted to bring it up today, because it definitely is something that bears more examination. So thank you for your question.
Madam Chair,
Representative
I
Kwan.
don't see DHS on here. Was there a plan to have them?
Not today.
Okay.
They're not speaking today
Thank
unless there's some particular reason. Representative Elkins.
Thank you, Madam Chair. Are the, in these ACOs, the different kind of managed care types of schemes?
Representative Elkins, it's kind of hard to hear you. I
Is it
don't know.
not
Is your mic on there?
Should be, yeah, it says it's
Okay.
on. In the Medicaid market, are we using many of the same quality metrics and risk adjustment factors that are also being used or developed for Medicare?
Representative Liebling and Representative Elkin, I think there are many similar. There's a kind of a certain, there's certain lists of measures that have been adopted and proven to be effective. And so like you have the HEDIS measures, and then you may have some others that are approved by another council. And so there is a defined list of quality metrics that are used across the systems.
Okay, so.
Representative Elkins.
Yeah, follow up then. So it's kind of tempting for us to, look at the Medicare market as a possible model, just because there is so much more data and it's already pretty intensively analyzed. I mean, for example, the Medicare Payment Advisory Committee does a very detailed comparison between managed care and fee-for-service whenever they do a report. And, in the 2023 MedPAC report, there's a statement suggesting that managed care is on average about, 17% cheaper than fee-for-service. Should we be careful about extrapolating that kind of analysis over to the Medicare side? Have you looked at that at all?
Dr. Blewett.
Chair Liebling, Representative Elkin, yes, I would be cautious of using Medicare as an example, except that the models are very similar in terms of how they're set up and designed. Medicare, of course, is administered by by the federal government. And so you do have, one system that covers across the country. And so you are able to collect data and see data. And so that's where most of the analysis is done. As Dr. Goldberstein, alluded to, it's very difficult to look at Medicaid ACOs across the country and compare them on apples to apples. So what you have is, each state doing their own thing and then trying to figure out, is this working or not working, using the data that's available at the state and local levels. So, but so critical to do that. And I think the NCSL talk this afternoon will provide some of that information. Yeah. Thank you.
Okay. Representative Breyer.
Thank you, Madam Chair. I have two questions, if I may. The first is about the patient experience. Imagine I'm a patient in an attributed population, and I'm in IHP. What does that mean for my network access, and what does it mean for the ability to have outcomes if I can go to a completely different provider group for services, or am I essentially captive within the IHP?
Dr. Blewett.
Chair Liebling, Representative Breyer, that's such a good question, and that's the complexity. How do you know what the costs or quality is attributed to? And I would recommend that you have some of the IHP administrators come and talk about sort of how they manage because they do have a population, and some of that population is fee-for-service, and some of it is managed care, and some is with one managed care, it could be with a different managed care. And so I think that it would be good to, open up that hood and take a deeper look. I think those are exactly the questions that should be asked.
My understanding, I may be wrong, but my understanding when you talk about attributed population, that the person themselves is not restricted in where they can go. That's why you have
Right.
to attribute it, right? Kind of use
Yeah.
data say who really belongs in this group and who belongs there, and maybe that's something you is that part of your question, Representative Ryer?
Thank you. Yes, in that the layers of complexity, which leads a bit into a different question, is we know that the MCOs can charge a certain amount, have a certain amount of cost for admin, and I imagine the IHPs can. Do we start to have layered administrative costs that add up to more than the administrative cost would be if we had a simpler structure?
Dr. Blewett.
Chair Liebling, Representative Ryer, yes, that's the question, right? Is this multi-layer system working effectively? And what are the administrative components and how do you attribute both the cost and the efficiencies and the quality to the IHP versus and I don't know the answer to that, but I think the department is probably more apt to talk about the administrative costs for each of those and maybe get into more detail on how it would actually work. But you're right, the patient isn't restricted to IHP providers.
Representative Ryer.
Thank you, Madam Chair. Not formally restricted. I
Yes,
wonder
maybe not
about
right.
I wonder about referral patterns
Yes.
and what happens in real life versus being officially limited to a certain network.
Yes.
It's harder to measure, it's harder to study, but those are the things that affect the actual experience for members. Thank you.
Thank you.
Representative New Brindley.
Thank you, Madam Chair. I've got just a couple of questions. The first is, I was looking over the slides on who is using the IHPs, and it says you have 550,000 beneficiaries. Can you just, I just did fast math. Can you just verify that then that bucket is part of the MCO bucket? So that's about 47% of the 82% that are using MCOs. Is that correct? Which would be 40% of all Medicaid patients across the state then are using IHPs. Is that what I'm reading there?
Dr. Blewett.
Representative, Chair Liebling, Representative Brindley, yes. That there are more than, 550,000 beneficiaries that are in IHP attributed populations.
So, and Dr. Blewett, some of those, though, are also fee-for-service, right? It
Yes,
isn't
I'm sorry.
exclusively
Chair Liebling, absolutely
people in
right.
MCOs.
There
but-
would be some fee-for-service, and I don't know the number.
But as Representative Brindley alluded to, we've got,
Yeah.
I think, 85% of our Medicaid patients are in fact in MCOs. So
Yeah, 82.
it's
Yeah.
going to be largely, I
Yeah.
believe, people who are also in MCOs.
Yeah. it's a good-
Representative
it's a good
Brindley.
question.
So Madam Chair, maybe this is a question for you. So are you saying that 18% fee for service is included in the 550,000?
Well, I think some would be. It's
would be.
probably more of a question for DHS to tell us. And I think this is definitely a topic worth exploring further. Clearly, I don't know that much about it. I would guess that most of us around the table don't know that much about it. And this is another one of those things that, is happening on our watch that we need to understand better. So, but I believe at least some of them, whoever is a patient who goes to a provider who is in the IHP system is going to be an attributed patient. Some of them are MCO, many of them are MCO patients. Some of them are going to be fee-for-service, I assume.
Yes. I
Yeah,
think that's right.
Representative Brindley.
Okay, thank you, Madam Chair. So then presumably it's difficult to know then, given the confusion on that question, it's difficult to know then if this population served by the IHPs has a similar numbers to those in managed care as far as the younger, healthier population of children, new adult group versus disabled.
Representative
age.
Liebling and Representative Brindley, DHS should be able to provide that information, like how many are fee-for-service and how many are enrolled in a managed care. I just don't have that information.
Okay. Representative New Brindley.
Thank you, Madam Chair. Clearly, this is confusing.
Yes. Yeah, thanks for your questions.
My other question is, you went through some of the metrics. Do IHPs, are they held to the same medical loss ratio, that 85%? Or is that calculated differently with the IHPs?
Chair Liebling, Representative Brindley, I don't think so. They are rewarded for total cost of care metric and quality metrics. So they're not providing, the whole range of services. Yeah, I don't think so, but again, that would be a DHS question. I don't know if you want to go further with this with someone from DHS, but.
Right. Well, maybe not right now, but
Yeah.
DHS folks are here, and I see them taking notes furiously. And so hopefully they can get us some kind of information to send out later to explain this more. And Commissioner, did you want to say something about it?
I was just going to say, our IHP team would be a great possibility for a future hearing.
Yeah.
That would be great.
Yeah, anyway, we will get further information, because clearly it's something we need to understand better. Representative Brindley.
Thank you, Madam Chair. Representative Schumacher is nervous that I'm going to get us into another hearing here before. But I would ask maybe offline to Representative Nadeau's questions about what happens with the savings. We would like to see that, because those are shared. It's not just a DHS question. Those are shared with the counties. So there is quite a bit of that revenue, that money, that is a savings for the counties. And so that is a good question that we would certainly like to know, how those savings are being used at the local level as well. Thank you, Madam Chair.
All right, thank you. Thank you for your questions. No, this is, yeah, this is, obviously, this impacts a lot of Minnesotans, a lot of the people for whom we're paying for their health care, and we don't understand it that well. So I think it's important that we get some more information and start digging into whether this is something that is serving us as it should be. So that is the end of my list of questioners. So Dr. Blewett, I think
Thank
you're
you
off
so
the hot
much.
seat here. Thank you so much. That was great, very, very helpful. And we're a little bit behind, but we have Dr. Baumgarten, or he's not, I don't know, doctor. He's not a doctor. I guess he's a lawyer.
Good morning, Madam Chair and members. My name is Alan Baumgarten. I'm an independent analyst. I'll take my mask off. I'm an independent analyst of healthcare markets. I publish annual market analyses of the payer markets and provider markets in Minnesota, Michigan, and 4 other states, and have been publishing the Minnesota report since 1990, when I was the research director of the Citizens League in Minneapolis, or St. Paul. My first job out of school was working for Jim Nobles in the Legislative Auditor's Office, doing program evaluation research, where I developed something of a niche in research on state Medicaid programs and also on health plan regulation. I also conduct project research for organizations like the Robert Wood Johnson Foundation, and much of my knowledge of Medicaid that I'm going to review this morning is based on research that I've done for the Robert Wood Johnson Foundation, for Mathematica Policy Research, under a subcontract with CMS, and the research that I've done in preparing the other state market reports.
Yeah, and thank you for being with us. Welcome to the committee.
Thank you. So I'm going to begin my presentation at a very broad level of talking about the Minnesota healthcare market for providers and health plans, and then later on drill into more detail about the finances of Medicaid managed care organizations, talk a little bit about the relationship between Medicaid and hospitals. I have a little bit to say about procurement processes and how states exercise oversight over their contractors, and a little bit of comparison with Minnesota and other states, and you'll hear more about what other states are doing during the afternoon presentation. So Senator John Brandel, who many of you might remember, used to like to say that Minnesota excels in recounting and retelling the number of ways in which Minnesota excels. So, but I do think it's important, and I get this question a lot, how is Minnesota different from other states in terms of managed care companies, in terms of the culture of health insurance and of provider care? And I would point to, I would think, 5 major differences between Minnesota and many of the other states that I study. The first is the limited presence so far of national insurance companies, even though we are the headquarters of United Healthcare, and United Healthcare has sold different Medicare and employer products in the state for many years. There's actually a very limited presence of national insurers in the state. If you look at premium revenues, United Healthcare and Humana are the 2 largest national insurance carriers doing business in the state, and combined they have about 8 or 9% of the market. It's growing, or at least it's growing in the case of United Healthcare. Humana's share has actually declined because they've lost a good number of their Medicare Advantage enrollees, partly because of provider systems that have decided to go out of network with Humana products. The moratorium that was enacted in 1984 on constructing and licensing new hospitals, new nursing homes, new group homes for persons with developmental disabilities has had a very significant impact on the development of provider systems in the state and the level of competition of provider systems in the state. In many of the states that I study, even in states like Wisconsin or Michigan, where there's very little population growth, there is still significant new investment in building new hospitals, which is not to say that we don't have significant investment in health facilities here in Minnesota, which we do. We have the Alina system, for example, building a replacement inpatient tower at Abbott Northwestern. But I would say that over the years, it's led to much less capital investment than other comparable states. The years of consolidation on both the health plan side and the provider side have led to very highly concentrated markets for both payers and providers. I do a calculation in my reports where I show, if you look at the health insurers in the state, based on their premium revenues, what is the percentage of the market that the 3 largest insurers have? And in the case of Minnesota, it's about 72%. And that's higher than any of the 6 states that I study, except for Colorado, which is 72.2%, or some other very small difference. Similarly, and I'll show you a slide about this in a minute, the provider market here in Minnesota has become very concentrated. And that has led to a very high percentage of physicians in hospitals that are within systems, even with critical access hospitals in rural areas. And Minnesota has, I think, the 2nd or 3rd largest number of critical access hospitals of the states. More than half of them are part of larger provider systems. And something that surprises people sometimes is that there's a relatively very low use of capitation and other kinds of risk sharing with providers here in Minnesota. If you were around in the 80s, there was a fairly large amount of risk sharing with providers, and then providers, to a large extent, rebelled against that and said, if we can't control the expenses with the tools that you've given us, then we're not prepared to take risk for the amount of money that we spend on it and the amount of money that you're willing to pay for it. So Minnesota is largely a fee-for-service system, particularly with regard to commercial group insurance. So when we talk about trends for provider systems, I would say that they've been going beyond state borders in order to seek further growth. For the most part, they've been overall profitable. I know there was a release from the Hospital Association just a week or two ago lamenting the financial difficulties that many hospitals were experiencing. I think that the picture is more nuanced than the Hospital Association report might have portrayed it, in particular because they left out numbers for the Mayo Health System, which has been reporting very healthy profits through the first 3 quarters of 2023. Inpatient days have been flat or in some cases declining in hospitals. And in a few cases, we see hospital systems downsizing their inpatient facilities and making other kinds of investments, such as ambulatory surgery centers, urgent care clinics, or other kinds of ambulatory care clinics. Medicare and Medicaid cover a growing share of hospital care, which in a sense makes the hospitals more vulnerable to changes that have been considered in the past from government policies. It wasn't that long ago when the Republicans had control of Congress that there was a lot of discussion of capping or payments for the Medicaid program to the states, which would have, I think, had a significant impact, a deleterious impact on providers in the state. So I mentioned before that it was a highly concentrated market. This slide, based on 2021 Medicare cost report data, shows that based on net patient revenues, 3 systems, Fairview, Allina, and Health Partners, control 71% of the market in the metropolitan Twin Cities area. This shows net income for Twin Cities hospital systems over the last 10 years. And in, I think, 4 of those 5 years, the Twin Cities hospitals have enjoyed net income above $500 million combined. On the other hand, inpatient hospital days have been flat or in some cases declining. In 2020, the first year of the COVID pandemic, inpatient hospital days declined by about 10%. And this was something that was seen not just in Minnesota, but in most other states as well. There was an expectation, I think, at the start of the pandemic that hospitals might be overwhelmed by the number of patients that would go to them. And there were, of course, many new patients coming to them because of COVID. But at the same time, many other potential patients deferred care, not wanting to go into a hospital or even into their physician clinic to get care out of fear that they would contract COVID in that setting. So the number of inpatient days bounced back in 2021, but not to pre-pandemic levels. Let me say a word. Professor Goberstein spoke about this too, but let me say a word about the expansion of market boundaries for provider systems. In Wisconsin especially, you have several examples of highly regarded regional systems that are merging. The Freighter system, which is closely associated with Medical College of Wisconsin, is in the process of merging with the ThedaCare system, which is in Appleton in the Fox Valley. The Gunderson system in the La Crosse area is merging with the Bellin system in Green Bay. We have the Essentia system, which is in the process of merging with the Marshfield Clinic system, which is a major provider in central Wisconsin. And there's also, and I documented this in my most recent research for the Robert Wood Johnson Foundation, there's also a significant amount of construction going on of new hospitals and other new facilities in Wisconsin, even though the population there is largely flat. Most of these hospitals that I mentioned in Wisconsin, or most of these mergers, are non-contiguous mergers because the Federal Trade Commission, to this point, has largely given a pass to mergers in which the two provider systems do not have overlapping service areas. But the Federal Trade Commission and the Department of Justice at the federal level are considering new guidelines or new guidances about how they would review these mergers. And I think we're not that far away from the next large non-contiguous merger being subject to a vigorous review and possibly challenge by either federal or state antitrust regulators. And I give some examples here of other non-contiguous mergers on the national level. Health plans, our Minnesota health plans have also been expanding into other states. Medica sells individual insurance in more than 7 states now. And it also made an acquisition of the Dean Health Plan in Wisconsin and affiliated health plans in the St. Louis area. Health Partners has ventures with other providers or other insurance companies in 5 Midwestern states. Looking briefly at health plan trends, the overall trend for enrollment has been growth, especially for Medicaid and the other public programs, Medicare Advantage, and to individual plans, although that's still a very small, perhaps less than 5% portion of the health insurance market. We've seen some modest declines in Medicaid enrollment because of the unwinding after the conclusion of the public health emergency. The numbers I saw from August suggested that about 38,000 persons whose eligibility had been reviewed again had been dropped from Medicaid coverage in Minnesota, although it was very possible that some of them were able to pick up new coverage either through employment or buying heavily subsidized plans on the exchange, on Insure. And I want to say one more thing. I was asked about, what does the growing presence of United Healthcare and other national nonprofit health plan organizations, health plan companies, how does that affect the Minnesota market? And I will confess that I'm very cynical about the distinction between for-profit and nonprofit healthcare when it comes to either hospital systems or health plan companies. I think they're all motivated by very similar incentives. I think if you look at both the health plans that are nonprofit here in Minnesota or the major hospital systems, you would find that they have highly compensated executives, that they will distribute their net income in different ways that benefit executives or that benefit the parent organization and allows them to make investments or expansions into other markets. And I would also say that the research that I've seen on hospital systems suggests that for-profit health systems and nonprofit health systems will exit unprofitable lines of service at the same rate. So we have a crisis in Minnesota and many parts of the state with the closing of maternity facilities in hospitals, maternity units. And if you look at other states where there is a balance of both for-profit and nonprofit hospitals, you will find that an equal number of them are exiting the maternity line of service. Both for-profit and nonprofit hospitals will exit lines of service if they can't run them profitably. Let me say a little bit about enrollment growth in HMOs. HMOs in the 70s started mostly as a insurance alternative for employer groups. Over the years, employer groups left HMOs in large measure. Some of them, many of them in Minnesota became self-funded and contracted with Blue Cross Blue Shield or other insurance companies as third-party administrators for their, to pay claims and to establish network contracts and so on for their employer group benefit plans. We've seen growth in Medicare Advantage enrollment, but most of the growth is in Medicaid and the other public programs, which now are about, I think the number is 72% of all HMO enrollment is in the Medicaid and the other public programs. Minnesota HMOs recorded record profits in 2022. And I'll show you some more detail about that in just a minute. Their profits exceeded $600 million for the first time ever. It was, as we'll see when we look at the Medicaid program, that the revenues coming into these insurers increased much faster than their medical expenses did. And so the spread, that's the difference, the delta between premium revenues and medical expenses, the spread has grown considerably, at least in 2022. And the early reports for 2023, we have data through, I think, I have data through the second quarter, shows not the same high level of profitability, but still a strong level of profitability in 2023. I wanted to show you what that looks like for the Minnesota public programs, which include Medicaid, prepaid Medicaid, and also other programs like MSHO, Minnesota Senior Health Options, Minnesota Care, MSC, et cetera. And again, they reached a record level of over 700 million in 2022. I would point out that in 2020 and 2021, DHS imposed a risk corridor on the Medicaid health plans, basically saying that if you had a medical loss ratio that fell, let's say, more than 2 percentage points below 85%, then the state would recoup some portion of that additional profit that comes back to the health insurance company. The state is also saying that we will share risk with you on the upside. So if your expenses exceeded 85% by more than 2%, then the state would, in a sense, bail out a portion of those losses that might accrue to the health plan.
And
So
Mr.
I wanted
Baumgarten,
to-
just to put a point on it, here, that's me over here. I just, on this slide, when you, underwriting income, that's the one we're on, right? Yeah, so you're talking on this slide about their profit, essentially.
Yes.
Yes, just want to make
Madam
Sure
Chair.
that's clear.
Yes.
Thank you.
The difference between underwriting income and net income, and I don't want to get in the weeds with accounting terms, but underwriting income is saying, we took in this much money in premiums, and we paid out this much in claims, this much in administrative expenses, and here's the underwriting net, whether it was a loss or a gain. And then there's also investment income and federal income taxes for some companies, very few in Minnesota. And so that would give you the bottom line number. So let me show you a little more detail about what's happened in the last 3 years, specifically with the Medicaid plans. The amount of revenue coming to the Medicaid plans has increased by 52.5% between 2020 and 2022. The per member per month revenues, and I already heard some members mention PMPM numbers, so I think there's some familiarity with that, but I'll describe it anyways. If you take the amount of medical expenses, for example, for a health plan, and you divide that by member months as the denominator, you get a per member per month number. And that's a frequently used analytical tool when you're comparing revenues, when you're comparing expenses for health plan companies or insurance companies in general. So you see that that the PMPM revenues increased by 20.1% between 2020 and 2022. But the medical expenses on a per member per month basis increased by half of that, by about 10.8%. So as the delta or the spread between revenues and medical expenses widens, it results in very healthy profits for these companies. The medical loss ratio was 89.8% on average for these companies in 2020. By 2022, it had dropped to 82.9%. And the profit margin, which was all of 1% in 2020, grew to 7.1% in 2022. I have numbers. There were questions before about how do the county-based purchasing plans compare with the HMO category of plans, and I have numbers in the annual report that I do for Minnesota, and I'd be happy to share that with the chairman after this meeting. I mentioned that there are other Medicaid programs that go under the heading of state programs, and I wanted to just briefly mention some of the financial results for those programs as well. The biggest of the group is Minnesota Senior Health Options, which paid $2 billion in revenues to Minnesota health plans in 2022. It's a much more expensive program. The per member per month revenues are about 8 times the revenues for a standard Medicaid patient, a Medicaid enrollee. The medical expenses are also much higher, but still the medical loss ratio came out at 86.9% for senior health options, and the profit margin in 2022 was 7% for them. And Minnesota Senior Health Options, it's not just about one really good year. Minnesota Senior Health Options, if you look at the last 10 to 15 years of data, has been consistently very profitable for the health plans. I have some data here about Minnesota Care, about special needs basic care, and another program that serves a population that has disabilities and may be dually eligible for both Medicaid and Medicare. I think it's important to point out that Medicaid as a payer pays for 27.7% of inpatient days at hospitals in the Twin Cities area, 21.6% of hospitals serving greater Minnesota communities. And I use the phrase serving greater Minnesota communities because if you go, for example, to western Minnesota, there are basically very few hospitals on the Minnesota side of the North Dakota border. All the hospitals are in Grand Forks and in Moorhead. And the hospital systems in Sioux Falls, Avera and Sanford, provide significant service to Minnesotans living in those southwestern counties. So we said that 27.7% of inpatient days were covered by Medicare. It's likely, and I don't have those numbers, it's like a much smaller a smaller percentage of overall revenues are from Medicaid for those hospitals. Let me say a little bit about the procurement process. And Professor Goldberstein already has outlined a little bit about this, but it's a very demanding process, and the skill with which the state Medicaid agency is able to execute on these processes says a lot, I think, about the success of a Medicaid managed care program in achieving state goals of improved health status, of improved access, to high quality care, and so on. So there's a lot of analysis that goes into how you write the request for proposals to select the contractors. There's questions about what's the best number of managed care companies to contract with. If you contract with a small number, that is helpful because it means that your actuaries, your quality assessment staff people, they can provide much closer oversight of each health plan because there are not that many health plans to look at. On the other hand, you might want to have more competition, have a choice of more health plans so that the enrollees have more choices of health plans, and so that the state can manage market share and direct market share to those health plans that are superior performers. You need to determine the length of the contract term. Both the state and the successful health plans would like that contract term to be as long as possible, at least 5 years, even 7 years if possible. To go through the process of preparing the RFP, evaluating the proposals, and making the selection is all consuming for a state agency for a year or more. And so they want to, in a sense, get the best return on that investment by stretching the length of the contracts. And if you're a managed care company that is bidding on those contracts and you're making investments in expanding your provider network to get into other regions of the state, or you're spending a lot of time on competitive analysis and on preparing the proposal, you also want to be able to spread that investment over a maximum number of years. Some states, and I'm thinking of both Michigan and Arizona, have done, I think, a very good job of linking their managed care company selection to state goals and strategies. So, for example, Arizona has been on, I would say, a 10-year path of better integrating care And they've done that by expanding the contracts that they award to managed care companies. So it used to be 5 years ago that mental health, behavioral health was carved out of the managed care contracts, and the state contracted with separate regional behavioral health authorities to coordinate behavioral health care for Medicaid enrollees. In a procurement about 5 years ago, the state said, we're looking for health plans that can do both. We want to integrate behavioral health with physical health. We want to deal with a single entity that can demonstrate that they have the capability of doing the kinds of care management and care coordination that we're looking for. In Michigan, the state has not used payment rates to the health plans as a point of evaluation in their procurements for more than 20 years now. Instead, they have a robust data warehouse of data on utilization and demographics and healthcare costs. They work with their actuaries to set the rates that they're going to pay, and they put that out to the managed care companies and say, this is what we're prepared to pay you. Now show us how you can give us the best value for those dollars. And they use that rate setting process to set the numbers at a level that will attract a lot of bidders, a lot of interest from bidders, but will not give away more of the public's money than it absolutely needs to. One of the things that you're looking for is mechanisms for managing market share and how the auto-enrollment algorithm is used. I haven't seen recent numbers from Minnesota, but in the past, more than 50% of new enrollees to Medicaid did not choose a managed care company on their own. And so the state has an algorithm for saying, well, if there's another family member that's in Health Partners, then we'll put you in Health Partners too. Or if you've been seeing a doctor who's in the Blue Plus network, then we'll assign you to Blue Plus. But states can use that algorithm to reward health plans for good performance or to penalize health plans for poor performance. So they can say that if you have very high scores on evaluation measures like the HEDIS scores, we want to reward that. And we want to say that you get a higher than average number of new enrollees coming to you through the auto-enrollment process. And if your numbers fall below our expectations on HEDIS scores or other evaluation measures, then we're going to say, we're going to limit the number of new enrollees that you get until you can demonstrate to us that you can improve your performance. So I already spoke a little bit about how Minnesota compares with some of these other states. Let me mention Ohio for just a moment. Ohio has a very large Medicaid managed care program with more than 3 million Medicaid enrollees in managed care plans. It went through a lengthy process about 3 years ago now to identify what was working well with Medicaid managed care and what needed improvement. And they were also acting out of concerns that maybe there were some areas in which some of the health plans were taking advantage of certain relationships. And the Attorney General sued some of the health plans because they were basically using affiliated companies to manage the prescription drug benefits. And they were keeping some of the money that the state expected would go to the local pharmacies that were filling the prescriptions. So that company was Centene, which is, I think, the largest national company doing business in the Medicaid managed care space. And eventually they reached a settlement with Centene in which Centene paid, I think, about $70 million back to the Medicaid program. Ohio was just coming out of the procurement process and announced that it had selected bidders and that it was putting Centene's bid on hold pending the settlement of this lawsuit. Centene's proposals were very highly rated, and normally it would have been a slam dunk for them to get their contract. But I think the state used that contract possibility as leverage to get what I think was a very healthy settlement. But beyond that, the state, in this next procurement, said, we're going to carve out prescription drug management, and the state is going to employ a single prescription benefit management company that reports to the state, not to the managed care companies, and certainly is not owned by one of the managed care companies. And by doing that, the state expected to save in the vicinity of several $100 million. The state also carved out some claim processing and some prior authorizations, again, selecting a single contractor to do that for all of the health plans that the state was contracting with. And I think this is my last slide. So I did a very back of the envelope comparison of how Minnesota compares to Michigan based on 2022 numbers for their Medicaid managed care programs. And I would caution that there are a lot of differences in how states administer Medicaid managed care, in what the benefits are from states to state, because there is quite a bit of variation. To what extent do states contract out or carve out some of these functions? But I would say that the difference is striking, that the average revenue per member per month in Minnesota for a Medicaid moms and kids and childless adults population was $550 per member per month, compared to $312 per member per month in Michigan. A similar relationship between medical expenses per member per month. The medical loss ratio on average in Michigan was higher, and the margins were lower. The average margin in Minnesota in 2022, which as I said before was a record-breaking year, was 4.6% compared to 2.8% in Michigan. So that is the end of my prepared remarks, and I'm happy to respond to any questions.
Thank you so much, Mr. Baumgarten. There's a lot there, and a lot. And really appreciate you being here to do this for us. And I would just say that Representative Herr had to step out, but she actually had a lot of questions, and I wouldn't dare try to recapture them, but I just would ask you if you can be available in the future. Maybe we can, I think there are probably a lot of members here who will want to follow up with some aspects of this, and it's just great.
And my contact information is on the last slide.
Wonderful, thank you so much. And Representative Quam and then New Brindley.
Thank you, Madam Chair. And it'd be interesting to see the detail of the impact of shifted or delayed procedures that have a higher, profit. There are certain procedures where hospitals always get more return for that, and there's competition. But during the years of the COVID restrictions, a lot of procedures were delayed and pushed back, and I noticed a large portion of those fell into the bucket of where they weren't a loss to the hospital. Some procedures, actually, hospitals lose money. Unfortunately, most of the hospitals are losing. So did you do any analysis to look at the impact of the delayed procedures and the secondary impact of the delayed testing, which caused more expensive or other procedures to be required because a condition had gone on for a year or more than it wouldn't have.
Right.
Baumgart.
Madam Chair, Representative Quam, I can't really answer that because I don't have that kind of data or that kind of analysis to share with you. I can tell you in very general terms that in 2021, when we thought we were somehow out of the pandemic, maybe, that there was an increase in measurements like inpatient days or inpatient admissions. So I have those numbers, but I don't have any numbers about, well, what did they go in for? What kind of surgeries did they have and so on? Since you mentioned, I should mention that the profitability of the hospitals in 2020 and 2021 did suffer because of the loss of those revenues, but was largely made up for by the federal provider assistance funds, which of course were mostly in 2020 and 2021, with only a little bit of that money coming to hospitals in 2022.
Representative Quam?
It'd be nice that as we members hit questions to him or the testifiers, that the responses come to the entire committee, because I think with all of us and the different ways we're looking, that data will be very useful to everybody. Thank you.
Yeah, thanks, Representative Quam. We do try to do that. Representative New Brindley.
Thank you, Madam Chair. And I'm wondering, I'm seeing different numbers here on the trends in revenues and expenses for Medicaid plans. On that slide for 2022, you've got a medical loss ratio of 82.9%. And on that last slide, you have a medical loss ratio of 85.2%. Do you know what that discrepancy is?
Mr. Baumgart.
Madam Chair and Representative, I would have to check my data set on that, but I will make a note of it and get back to you.
Madam Chair.
Thank you. Representative New Brindley.
Thank you, Madam Chair. When you're doing that, will you just check? I believe, and unfortunately Mr. Berg stepped out, but I believe that the state did do a clawback last year, so I'm guessing that it was under that 85%. And so I would also be curious to know that profit margin, if that was prior to a state clawback or after the state clawback, if that was the final profit margin, or if that was prior to a state clawback.
Madam Chair and
Mr.
Representative, it's my understanding that the state did a clawback, so to speak, a risk corridor in 2020 and 2021, but not in 2022. But in any case, the numbers for those years in which it applied a risk corridor, executed a clawback, those numbers, the amount of money returned to the state would have been subtracted from the net premium number on the annual statement. So those would be numbers of net income or profit margins after any clawback.
Representative New Brindley.
Thank you, Madam Chair, and thank you for that. And then my only other request, as you're gathering a little bit of additional information, is if we could pull back a little bit further than just 2020, 21, and 22. Obviously, those were sort of odd years for obvious reasons. I'd be very interested to pull back and see maybe the last 10 years and what those trends were.
Great, thank you.
Thank you.
Representative Ryer.
Thank you, Madam Chair. Thank you, Mr. Baumgarten. On the health plan trends, we talked about whether the nonprofit, for-profit distinction matters, and I appreciate your point of view on that. My question is, could it matter? Do we have levers available that we're not using? Do you have a point of view on that, on how we could be holding the nonprofit sector more accountable? I bet we're not doing that. And also, if what the opportunity is to hold them equally accountable to outcomes and to profit levels.
Mr.
Well,
Baumgarten.
Madam Chair and Representative, I would say that the answer to your question lies partly in the history of United Health Group. Because until 2017, Minnesota had a law that you could not operate, you could not be licensed as a health maintenance organization if you were a for-profit company or a non-Minnesota company. And the people who took over Physicians Health Plan, which had been started by the Hennepin County Medical Society, and which was about to go into bankruptcy, I think, before they brought in new leaders. Those new leaders said, well, we want to operate this like a for-profit company, but the state won't allow us to do that. But the state law is silent on whether you could create a for-profit HMO management company. And that's the origin of United Health Group. And they created a for-profit management company for Physicians Health Plan at the time. And they took that model to different states. And, you know, as they say, the rest is history. So at that time, Physicians Health Plans had no employees. The licensed HMO had no employees. All the employees and managers and administrators were in the for-profit management company. So part of my point here is to say that you can create incentives, you can create legal barriers to try and get companies that are contracting with the state to provide medical services or to administer health insurance benefits, to get them to adopt a mission, a community approach that's more aligned with what the state is looking for, but that these companies will do what they want to be successful as these kinds of companies. Now, the state, if it chose to, could give preferences based on how you're organized as a corporation, as a for-profit or as a nonprofit, as a stock company or as something that's largely owned by private equity. But my own personal view is that the state is better off hiring the best companies it can to run these programs if it chooses to go in that direction, and that's a debate that can be had. But since it has chosen to go in that direction, it should choose the best companies at doing that job regardless of their corporate organization. And I mentioned that I worked for the legislative auditor in the 1980s, and in 1988, we did an evaluation of how the Department of Health and the Department of Commerce regulated HMOs and other health insurers. And in that report, we said that if the state thought that requiring HMOs to be not-for-profit would inject a certain kind of, community-minded, community benefit orientation to those companies, it should know that that hasn't worked out. I think that there are opportunities for companies like UCare and Health Partners, which I guess I might say are truest to our notion of a nonprofit, a community benefiting corporation. I think there are opportunities for them, and I think they use them to tout that, to promote that as, let us manage your healthcare for you because we're the ones that, are provider-based or have the best interest of our patients in mind. So let me stop there.
Okay, thank you. And I have a couple questions myself, and I know we're right up against where we're going to stop for lunch, so I know it's dangerous to start asking questions at this point, but a couple things. One is going to your slide about flat or declining inpatient days for Minneapolis and St. Paul hospitals, and I know this only goes up to 2021, so it's a couple years behind, but we're hearing right now from hospitals that they are flooded with patients, largely due to the fact that they're having trouble discharging people. There aren't enough behavioral health facilities, and for various reasons, they're having to keep patients sometimes for a very long time. Is the newer data, would the newer data be reflecting that, or I'm just questioning sort of the inconsistency between that message we're getting and what your data shows up at least until 2021, if you could address that.
So, Madam Chair, my data source for the hospital analysis that I presented is Medicare cost reports, which each of these hospitals is filing with CMS through their Medicare intermediary. The 2022 complete set of cost reports just became available for download last month. And I have those, and I'm taking a look at them. I can tell you that the net income that I've seen so far for Twin Cities hospitals is down, but not down that much. And that the inpatient days are slightly higher, but not that much higher. So 2023, there are other sources of data. You can go to bond rating agencies, which are sometimes reporting as often as quarterly. They're getting data from the hospital systems whose bonds they rate. And you can sometimes put that together, but the Medicare cost reports have the benefit of being a consistently reported data source, whereas what you can get from bond agencies or what you can get from generally accepted GAAP audited financial statements is not consistently reported. And so I too am eager to see 2023 numbers.
Okay, and that Medicare cost report you said is that captures other kinds of payers though, right?
Right, it captures all payers.
Okay, and then my other question is, and maybe again, it's a lack of phasing in the data, but were we looking at the huge profits that you're reflecting in your report here that have been made in the MCO space recently? We're also hearing, you just referred to it, that hospitals are telling us, we're going under, our members, the Hospital Association is telling us, with difficult straits they're in, and we need to raise the Medicaid rates and so on, so on. And I just wonder, that's the hospitals. Of course, we've got Health Partners, which is both, both a payer and a provider system. But, how do you kind of bring those things together? Are the MCOs kind of making extra money at the expense of the hospitals, or, how do we understand those two things happening at once, if they are happening at once?
Madam Chair, I think if you're asking, is enough money going to the providers, specifically in terms of the Medicaid program, I will reply with the story of the former CEO of Methodist Hospital in St. Louis Park once asked me the question. He says, I've read your reports over the years, and can you explain one thing to me? You showed that Medicaid is the most profitable line of business for Minnesota managed care companies, yet it's my worst payer. Can you tell me why that is? And I said, I think the answer to your question is inside the question, that it's because of the strong profitability that stays with the managed care companies, in part because less money is going out to the providers to pay for direct care.
Okay, thank you. Well, on that note, gives us a lot of food for thought. Thank you very much for your presentation. I just want to note before we break for lunch, we do have some coffee over here in the corner that anyone should, who feels a desperate need for some coffee should come and get it while there's enough. I'm sure it's not enough for the room, but, please do use that. And so we are going to break for lunch, and we will be back at 1 o'clock. For another very important presentation along this theme. So thank you again, Mr. Baumgarten. That was extremely interesting. And I know that we're going to be talking to you some more in the future. So, thank you. We are in recess.